Okay, let me get that. Welcome, folks. This is House Corrections and Institutions. It is Friday, February 4th. And I know we're running a little late. We got tied up. There was some meetings that needed to occur, so members are tied up. So thank you, Katie, for having the patience. Thank you, Tony, for having your patience. We're starting with where we left off, page 32, which is updating our statutes. We don't have DOC in the room, that's okay. Updating our statutes in terms of the delivery of what used to be medically assisted treatment, which is now called medication, I forgot what it's called, for opioid use disorder. MOUD. And we started to go through the new draft. It's a strike all amendment to H 32 with our legislative council. And Katie, I'm trying to remember how far along we've got. I think
Page 7 or something.
I think it's half of page 8, but page 7, that we could start there.
yes, why don't we do that? And Katie, if you could just introduce yourself for the record.
All right. Katie McGlynn, Office of Legislative Counsel. Let me share my screen here. Okay. So, when we last met, we were walking through this draft 1.1. We didn't get all the way through our walkthrough. To remind you of where we were, there are 2 sections that we're sort of deep diving on that pertain to healthcare and correctional facilities. The first section pertains to healthcare generally, and we completed a walkthrough of that section. And then the second section is specific to MOUD, and that's where we last were. So I can pick it up from there. We were on the newly relettered subsection D. And we're, instead of a licensed practitioner, we're saying a healthcare practitioner. You remember a lot of our conversation was that we were adding a definition of healthcare practitioner. There was also some conversation about doing a deeper dive on what that definition might look like. Right now, it references Vermont licensure under Vermont statute, and there is a conversation about providers potentially being licensed out of state if the care was being provided out of state. So lagging that so we can continue talking about it. So the healthcare practitioner who makes the clinical judgment to discontinue a medication prescribed in the course of medication for opioid use disorder shall cause the reason for the discontinuance to be entered into the inmate's medical record, specifically stating the reason for the discontinuance. The inmate shall be provided both orally and in writing, both orally and in writing with a specific explanation of the decision to discontinue medication, with notice of the right to have the inmate's community-based provider notified of the decision. The inmate provides signed authorization to the department if the department can notify the community-based prescriber. So that language tracks what we already looked at in the previous section. Subsection D is reentry. This is being moved more than eliminated. It seemed to make sense to save reentry for the end of the statute. So hold on to those thoughts. And I think where do we tackle them? We tackle them in G. Oh,
Yeah, I didn't look at, I was looking at this and I'm thinking, where is it? I didn't see it because we really need. Oh, wait a minute, it is there.
It's in G,
It's in G.
but it's not underlined, even though I moved it. So I have
Why it was,
yeah, I'm not sure why I wouldn't have underlined it. Maybe I cut and paste it from up above, but having moved it, I probably need to underline it.
yeah, because I looked at that and I'm thinking,
Yeah, I understand your confusion because I just confused myself.
I'm not losing it yet.
You're not, no, maybe I am. Okay, subsection E. This has to do with rules. One change that we talked about when we last met, this says counseling and behavioral therapies shall be provided, and the change is offered in conjunction with the use of MOUD. The conversation we had a month ago when that decision was made was that individuals who are receiving MOUD don't have to take advantage of counseling or behavioral therapies, but it has to be offered. So that reflects current practice. And then this is referring to the Department of Health's rules on OTPs and office-based opioid treatment providers, so hubs and spokes. So we're cross-referencing that care is to be provided in a similar way. Should we also change MAT to MOUD there? Counseling for behavioral therapies often in connection with this. Use medication. The use of medication for opioid use disorder. Yeah. Unless Tony has a reason, I don't know why I didn't do it.
I think it has to
So-
be consistent.
Yeah.
No,
I-
hi, Tony Follen, Department of Health Division of Substance Use for the record. Katie, my assumption is that we actually missed that as we were updating our rule. So my suspicion is that came directly and we had missed the change. So please feel free to change that so it's consistent across the board.
Are you looking at lines 9 and 10?
7. I'm on 7.
7.
Yeah. I think Tony's being kind. I think that's me. So I will correct that. Subsection F.
But we're changing, I'm going to lines 9 and 10.
Mhm.
Is it still rules governing the MOUD for office-based opioid treatment providers prescribing bupe and opioid treatment providers? Is it still,
Same title.
well, because we're really, if you look at our language, we're opening up what type of medication could be used.
Yeah.
It's not just bupe.
So the opioid treatment providers would be providing methadone, and I'm assuming potentially you also.
But if they go to injectables,
But that would still be buprenorphine or I think naltrexone.
Yes.
that would still be considered bupe.
It would still be a medication for opioid use disorder. It has some different medical properties, but it would be consistent. The regulations would be consistent.
I'm going to write a note to myself to confirm that the name of the rule hasn't changed.
Yeah.
That's what that is, the name of the rule.
Yeah. Okay. Subsection F. Prior to community reentry, instead of as part of it, this is happening before community reentry. The department shall provide information and offer care coordination to an offender to expedite access to counseling, behavioral therapies, and medication for opioid use disorder within the community. So notice the change of word there. So this is offenders, not detainees. Prior to reentry, the department is doing this for offenders.
And does the committee know who the offenders are? Who are the offenders? Come on, folks.
An offender is an inmate, but not necessarily a detainee, right? Because a
Who are the
detainee has not been
offenders?
charged. It's
Who are the,
Sentence.
they're the sentence folks. It's not your detainees. It's your sentence folks. It's really important to understand some of that. Be
Well, they're
careful.
not necessarily housed.
Well, this is
In this case,
reentry. This is prior to community reentry. So they're serving an incarcerated sentenced in the incarceration. And they could be released on furlough, or they could be released on parole, or they could have maxed out and being released. So prior to their release, DOC needs to do work on their reentry. And it's not detainees, because detainees could be there for a very short period of time, or they could be there longer. In most cases, if they're there for a couple of years, in most cases, they are going to serve a sentence. They're going to be convicted and serve a sentence. In most cases, not all.
So the strike through and 3 on line 15 just brings those two paragraphs together because they both are talking about prior to reentry. The department shall identify a healthcare practitioner licensed to prescribe medication for opioid use disorder or an opioid treatment program or both, and schedule an intake appointment for the offender with the healthcare practitioner or opioid treatment program or both to ensure that the offender can continue treatment in the community as part of the offender's reentry plan.
So again, this is the change that we've made, the department and what we have right now in statute, it's contracting, right? Which would mean WellPath. And we need to be clear, do we keep or its contractor, or do we shift it over to the department, knowing that the department has a contract with WellPath?
It's a hard one.
Would people follow that one?
Yeah, I mean, I generally be in favor of leaving department, I think, because ultimately the buck stops at them. That's
And not do the contractor? Because it's the contractor who's doing the work now. That's what we did last year, Connor.
right. I do remember that.
We
Right.
wanted to keep everything based in terms of what the contract was, and it's the contractor who's making. And this is what we talked about last time when Katie
Yeah.
was here. It's the contractor that's making all
Mhm.
of these connections.
Yep,
It's not,
it's not the department.
it's not central office, it's not the superintendent. I don't know if it would be the case supervisor who's a DOC employee. I think we've got to really talk about that as a committee.
Mhm.
I know what we're saying is the department's really in charge of that contract.
I think whatever you decide, you have to think about it across both of those sections of law and be
Medical
consistent.
as well as the
Yeah.
MOUD.
Because any medical care that says, you have to provide medical care, provide an assessment, the department isn't doing any of that. So whatever approach you take should probably be consistent. Otherwise, it begs the question why a contractor is mentioned in one place and not the other. I had another thought about that.
I think, we need to get DOC in here to really have their lawyer
Yeah,
really talk about the language. Because we need to really focus on the language. So this would be a flag to really talk with DOC.
Does it legally impact anything, Katie, if like they're negligent, and the person who didn't get that done, would they sue the department or the contractor then?
Probably both.
Probably both.
Yeah.
Okay.
but the DOC said, and it's a law, that no matter what, at the end of the day, the commissioner is liable.
Because you're under their
It's
custody.
under his custody. And I can see both ways on the language, because the department is ultimately responsible for its contract. But like, in my mind, and it doesn't mean I'm right, by the way, at all, it's just like the way I read it. If it says we're a contractor, then the contractor, which is responsible for healthcare, is making healthcare choices, whether it's opioid use or otherwise. And they're not having to come back and saying, like, the way I read it, just if it's only the department, then the contractor, they go to Dr. whatever his name is, Oliker? Yeah.
Or whatever.
Yeah,
his name
you,
is.
so, and then like he would go, and he has to go to somebody in the department and go, hey, by the way, a medical thing that we've decided as doctors, we need to get your sign off. And like, that's the way I read it, most of his department, but doesn't mean I'm right at all, because I'm not a lawyer, it turns out, Katie is. But
So I have a couple thoughts if you're feeling uncomfortable about this section. One is, one is wordy, but you could say something like, the department shall provide or cause to be provided. But then you need to keep that up throughout all of this sections. But then that sort of acknowledges that they're not necessarily the ones providing the service. The second option is having some type of paragraph at the end. And I took a stab at it. That might not be the right language, but some kind of language that says any medical services or counseling or whatever required pursuant to these sections may be, the department may contract for those services to be provided within
I think we really need DOC and their lawyer here because, just reading this, the department shall identify a healthcare practitioner licensed. And, I just remember our conversations last year in the committee. We were real clear. It is the contractor that does all this work.
Mhm.
It is not the department. It is the contractor.
And,
It's WellPath that does the work.
yep,
I've got what may be a totally absurd question, but if an offender has completed their incarceration time, they're done. They've paid for their,
They've maxed out.
they've maxed out. And they
Okay.
move to Wyoming in the middle of nowhere. Are we required to find a practitioner in Wyoming in the middle of nowhere, or we're not? Or is this limited to they move to someplace in Vermont?
I don't think most folks go out on furlough or parole. There's very few folks who max out. When they max out, they're either already on furlough or parole. There's very, very, very few people who max out in the facility. Very few. And that's a question to ask for DOC. You may have one person in 3 years that maxes out from an incarcerated facility.
I'm just trying to
So
get.
that would be a question I don't know. I don't know on that. Usually, I don't know. That would be a question for DOC, but I know people maxing out their incarcerated setting in a facility is not the norm. It's very rare.
That, but
So I don't know if they were to move out of state, completely out of state into a real rural area. That would be a question to ask DOC. How do we do that? Because I don't have an answer to that.
I mean, I don't have an answer of what happens. The language on the page doesn't limit it to Vermont.
Right.
right. So
But that would be a question to ask DOC. Without
how do
comment,
we remember that?
write it
just
down.
write a note, write a note.
Take it out.
Because we'll be going back to this draft over and over.
One thing I just want to be careful of, and I think it's fine if it's like department or contractor, but I wouldn't want to box us in to say that maybe I'm a dreamer today. There might be a scenario where DOC pulls these services in-house, and you're referencing a contractor when it actually is DOC, state
That's why we
employees
said the
providing.
department or its
Or.
contract.
I think or is okay.
I know we spent a lot of time on this
We did,
last
yeah.
year and we wanted to make sure it was
Yeah.
the contractor
Because your concern is
doing the work, because if you see the department, I'm just wondering if at some point there's gonna be an issue between the contractor and the department, say, hey, it says the department. Yeah, we have a contract with you, but we're not liable.
in your case, like, so if the way it's written there, it takes care of that, but if it said the department's contractor, then it would be,
Yeah,
that would be
yeah,
like,
yeah.
your point would be like 100% right there.
If you feel strongly about the or its contractor language, that's fine. But it begs a question why we're not using it everywhere. And so I think you want to be consistent.
Because it's not, and you're talking about the medical piece.
Yeah, I mean, this is only used in this subsection. Like we only start using or its contractor in the last few subsections of that section. So half of the section doesn't use it at all.
Because we were only really we worked on the medical health last year, but not in depth. We did more work on. Yeah, I'm looking, because the medical piece was done years ago, more so than the MOUD piece. And we were really looking in terms of medication when someone is released from the facility. That was our focus last year.
Yeah.
It wasn't looking at the underlying law.
I mean, if you look at page 6, subsection B, the department shall determine when an inmate is currently using medication.
On
So, like, it seems like if
page 5 is the other one, and it goes back, because it's all department before that.
it uses that version because those are the prescription sections that you amended last year.
I just agree, it's the only other place that.
Yeah, it goes, It's inconsistent. That's my point. I don't have a particular
Yeah, so
strong
let's
feeling.
let's flag that, because I really want to have a conversation with DOC on
Okay.
this. Okay.
Interesting.
Because last year, we really just focused on the sections. Medical as well as the opioid treatment. We were focusing in this committee last year on making sure there was a seamless transition for their prescription for the medication. That was our focus last year. It wasn't looking at the underlying statute that pertained to medical care or MOUD care. It was the specific part to make sure they had that medication when they re-enter. And our discussion on all of that was what is it in the contract with WellPath? And what does WellPath currently do? And we wanted to mirror that in language. We wanted to put that in language. So that's where some of the, and I don't know if that helps explain it or.
No, I understand where it came from and, you know, your process. If I were a court, which I am not, and who ever knows exactly, you know, what will be the outcome, but that would be something that I would get stuck on, the distinction between sometimes department is used and sometimes department or its contractor is used. So I think it's worth thinking, being thoughtful about that decision throughout.
Yep. James?
First time raising my hand today, trying to be good. So in your expert legal opinion, so when it says the department, does that infer does it infer the contractor or anybody else they do, like to your thoughts, or?
I think it's tricky. I think we often do give responsibilities to the to not DOC necessarily, but departments generally. And we assume that they're going to contract out for those services. In this case, you know, looking at this narrow universe, it's clear you already have a contract in mind. You know, that's the process you're following and you're concerned about it being misconstrued. So why not clarify your intent?
Okay. Thank you.
Other questions? Are people following along okay?
Yeah.
Okay. Wait until you get to report the bill.
Yeah, that'll be fun.
Then you're gonna say, what does it say? What does it mean?
Sean's got
I won't go that far.
it.
Okay, well, turn up the heat. Put on a jacket.
It's my hands and stuff that are cold.
Sit on them.
I know, right? Anyways, moving on.
There you go.
I got problems.
Okay, keep going, Katie.
Okay, so where were we still on?
I don't know, we were at the bottom of page 9.
Okay, so that's still subsection F, one last sentence. The department may employ a caseworker or contract with a health navigator to assist with scheduling any healthcare appointments in the community. So I think we heard from DOC that terminology was right, that we employ a case manager but contract with the health navigator. So that's why that change was made. Subsection G is moving around existing language. When you see a new draft, I will underline it so you will see that it has been moved from one place to another.
Mm-hmm.
As part of reentry, this is actually maybe helpful though, because you can see what has been changed from the original. As part of the reentry planning required pursuant to this chapter, the department shall commence medication for opioid use disorder prior to the offender's release if the offender screens positive for an opioid use disorder, medication for opioid use disorder is medically necessary, and the offender elects to commence medication for opioid use disorder. The medication for opioid use disorder is indicated, and despite best efforts, induction is not possible prior to release. The department shall ensure comprehensive case coordination with a community-based provider. 3, if an offender or detainee takes medication prescribed in the course of medication for opioid use disorder while incarcerated, and that prescription medication is both available at the facility and clinically appropriate for the offender or a detainee at the time of discharge from the correctional facility, the department shall provide the offender may provide the detainee at the time of release with a legally permissible supply to ensure the offender or detainee may continue taking the medication until obtaining medication in the community.
And what we were talking about last year in this, because this is current practice. For MOUD, they only give enough medication to the person until they can hook up with a provider in the community.
Mhm.
And that could be 2 days with medication, could be 5 days worth of medication. And we want to make sure that, and the other thing, we really put the onus more on the department and its contractor to make sure that there is a follow-up appointment.
And I asked this question back on page 5 in the non-MOUD part. I don't remember if we had any sort of discussion on it. Do we want to provide criterion for that may? Prior to this, like the criterion for may providing to the detainee?
Why?
Policy choice.
18.
Good.
I'm asking the committee more so. Do we want to list some criteria there? What would trigger the may?
That would be, I think we really need DOC to come in and testify on the bill. So this would be a question for them. And what would that criteria be if we did want to put criteria to trigger the may?
You'd have that question then for both sets of prescription language, because you have detainees in both.
Yeah.
Okay.
Hmm.
We've made it to page 11. There was a conversation a month ago about whether or not there should be training for DOC staff with regard to MOUD in terms of why individuals might be on MOUD, signs and symptoms related to having an opioid use disorder, and there is no resolution there, so I was asked to flag it, so I have flagged it for you.
I know it's Friday and people are really tired.
I'm a fan of providing that sort of training. I would like that sort of training myself. It's a May contract. Well, like, is there a
This is
statement?
subsection H, where it's in yellow.
Oh,
We
so
have
it's
nothing
not,
written yet, yeah.
that's not related to the I provide the train. Oh,
This is
is that the
about
trainer? No.
This, I'll
Okay,
get to it. This
yeah,
was
yeah,
my
yeah,
attempt
okay.
to say instead of putting our
Okay.
contractor everywhere, to say department could contract
Should
for
there
these
be
services.
training of
I
our
got you.
staff? That's really,
That's what
I-
H is asking.
yeah, should there be MOUD training of our staff?
I would want to hear from DOC as to
Yeah.
whether or not that's feels too much, but I'm always a fan of training.
Well, yeah, but it's so vague. I mean, you might want to hear from VSEA on that too.
She just flagged it as an issue for us to discuss. That's why it's vague. It's just flagged to say, hey, do you want to vet this and bring in testimony and talk about this?
Yeah, well,
Will and then Connor.
I know that DOC had mentioned that people that work at DOC, that they don't necessarily understand the MOUD the way that maybe they should or do, and I think part of that's because of the education. So I think it would be good to include.
Connor?
Yeah, I would just want to tread carefully, both looking at the understaffing issues and the allocation of time resources on this, but also some collective bargaining stuff. And what I really want to make sure is that we're not using COs to provide care that should be done by a medical provider. So I just want to be really careful with that language.
Other folks? So when this was all rolled out, there was a lot of pushback from the staff,
From the DOC staff.
correctional officers online.
Yep.
And And I think one of the reasons why we wanted to highlight this to see if it's something we want to address at some point in their training is because there's a feeling that there's a real lack of understanding of what the MOUD program is.
Yep.
Some of the staff may feel that while you're only keeping them addicted, this isn't helping. The staff, it's frontline staff that are there managing those lines, the med lines, and also making sure there isn't diversion going on. And if there isn't the understanding of why there was a medical decision to put someone on MOUD, there's a lot of misinterpretations that can be used in a facility in terms of how it operates. And managing the folks that are part of the program.
Outside of their academy, they don't have it, right? Like you have like a little bit in the academy,
I'm-
that's it.
I'm not sure how much they have in the academy, and that's one thing we wanted to have some testimony on at some point from DOC in terms of what their training is and the curriculum for their academy for that. Huh?
Yeah, like you're saying, I think it would be part of a broader curriculum, because if you're a CEO, you're sometimes dealing with like in-camps coming in and, okay, are they ODing? Are they just drunk?
Right.
You need to know all that kind of stuff. So I could see that being part of the overall training. But again, I'd want to be careful. We're not pushing this off on them when it should be healthcare providers.
Right, but there needs to be some understanding
Yeah.
of why someone is on the program.
Mhm.
And I think that's what was really, really missing when this was first rolled out. There was a lot of angst in all the facilities from the staff and a lot of, I don't want to say resentment. It wasn't resentment. It was just why are they getting all this medication? Why do they need it? So I think that's why it's kind of an important conversation to have. For that, because if you've got folks who are managing the facility and they're not comprehending why someone is on a certain medication.
Yeah.
How can you supervise in a healthy way? That's where some of the thought was coming from, I think. And that's why Katie highlighted it, so we can have some further testimony.
Should I continue to hold on that one for a while?
Yeah, because we gotta get some folks,
Frankly, people like myself would be asking the same question.
right,
Are we trying to detox everyone that's in there for more than a year? What's the rationale for continuing to medicate as opposed to help them get clean?
so that could be a question for Tony, because that's Tony's field of work.
Yeah.
So Tony, hang on to, can you answer that right now while it's fresh? Did you hear him?
Did you hear the
I
question?
did. I think the majority reason is the fact that, again, if think of it, you're in an incarcerative setting, you can stop using the substance. Most folks are sitting there waiting to get out. Many are frustrated. They are coming back into a world that hasn't changed for them. And their first use of substance, if they relapse, is most likely a lethal use. So they have no skills that necessarily generalize to being able to stay abstinent for substances. They've stopped using in the facility, but their adjustment doesn't necessarily put them in a situation where they're going to be safe. And what we actually see is for folks who are not on medications for opioid use disorder, who leave incarcerative facilities, their death rate is 129 times the general public.
Because they go for a quick fix, right?
They almost, it becomes I don't want to say universally, but it is, their relapse rates are astronomically high. And what's happened is they have no tolerance at that point. They've lost all of their physiological tolerance. So their first use is often a very lethal use. So if you look at those first few weeks, you see a significant death rate of individuals who have left facilities who are no longer on medications because they've stopped, but they are not in a position where they are adjusted to the point where they can manage the stresses in the world that they're coming into, and their access to substances is high again.
So that would imply to me that our expectations for anyone that's incarcerated are very low for them to ever have a life without opioids.
What we look at is, let's get folks back into the community, let's get them stabilized and adjusted, and then we can taper them off if they are able to stabilize their lives, then we can taper them off after they've adjusted back to the community.
I hear you.
Any other questions on that piece? For folks? Okay, and the other thing too, Tony, it would be probably helpful on this particular situation, this particular question that Kevin asked, is also to hear DOC's reaction to this from their medical folks as well, because I think they also can substantiate what you have just testified. They see it too. Sean?
Tony, is that the explanation you gave, which is great to hear. Is that the addiction? Or is that the space they're in? Is it a mixture of both? Is it the prison being as depressing as it is? I just want to know a little bit more about is there anything else we could do? I know that's anyway, thank you.
Yeah. I mean, I would say it's a combination of all those factors. So when you think about opioid use, you actually do make some systemic changes to the brain. If you think about folks who use opioids, their initial withdrawal symptomology tends to be 14 days where it's very acute, but they're what's called post-acute withdrawal symptoms, the body's ability to re-regulate itself to the best of its ability can take up to a year. So folks still don't feel right for up to a year. And then what happens is, if you think about it, folks are contained not because of their choice. They're contained against their will. Their first goal is to get out, and just transfer of skills between any settings is really complicated. If you're in a facility, and again, could be a DOC facility, it could be a nursing facility, could be in any facility, your lives are very regulated in a way that doesn't happen when you move into the community. And those skills that you learn have to then be readjusted to the community. You don't have ready access. Your friends and your peers and everybody that you were using substances with before are not sitting there waiting for you to be home, waiting for you saying, you're back. Let's get together and do what we were doing before. And so any skill level really has a hard time just traveling between kind of contained, controlled environments to the world you live in, where we're focusing on everything that's happening and being thrown at you.
Thank you for that. Appreciate it.
You folks will experience this when we adjourn.
Yep.
Trust me, you will experience a real shift
Yes, you will.
when we adjourn. It's going to take 2 to 3 weeks to adjust being back in a normal, regular community versus the State House. It's going to take a long time. It takes about a couple of weeks
Every morning.
to really
No,
make that shift.
It's different, trust me. You'll notice.
And it's different for folks who stay up here during the week versus folks who commute, but you're still going to have a transition time because it's going to feel really strange for the first few weeks to be back in your local community with a whole different schedule and a whole different group of people around you.
That's the
I
thing.
get so sad when everybody leaves my town. I just don't know what to do without it.
So what Tony just said of someone who has
Yeah,
been
the same thing.
institutionalized, whether in a correctional facility, a hospital, if you've been in a hospital for a couple of weeks and you come out, it's a whole different feel when you come back out into the real world. So any form of institutionalization where you're limited in terms of your comings and goings there's a transition there back into the community, and that's when you're most vulnerable.
And if
Well,
you
that's-
overlay that with the addictive piece, the physiological piece, if you think of opioid withdrawal, most of the time you think of a significant stomach flu. So if you think of having severe stomach flu, you hurt, you ache to the point where your hair aches, and then it's over in a few days. But to then feel really better is a process. We don't just stop and all of a sudden we feel better. It takes 2-4 weeks, depending on how significant that illness was, before we get back to feeling like ourselves. They're getting back to feeling to the best that they can, given the adjustment of the brain, and some of the adaptation of the brain can take up to a year. So you have this, I don't feel right, at the same time as I'm readjusting to a stressful situation, and my access to substances and the people I've used substances with now is substantially higher than it had been. And I am in control of my world now versus being in a contained environment. It's a recipe for folks, again, up to 129 times the death rate of all cause morbidity of the folks in the general public.
Yeah. I understand. They need to want to be clean more than feel good getting out. So they have to have something that's more important than being medicated. That's what we would love to have happen to every individual that we have to incarcerate, is that we give them or help them gain skills that allows them to say, I want to be able to do this more than not be able to do this. I'm pontificating, forgive me, but it's just all the more reason I'm so thankful. I've got 2 sons that survived and are productive. And I'd like to see that for everybody that's incarcerated for more than a year, 2 years, 3 years. That should be the goal. I'll try not to say it anymore.
But I think that is what we're trying to achieve here with our treatments, that is the goal, that folks, when they come back out in the community, will be able to have a positive reentry and adjustment in the community and not go back into criminal behavior or addictive behavior or become reincarcerated. That's our goal.
Right.
That's our goal. And in some ways, it's very similar to an alcoholic.
Right.
An alcoholic can say, well, I'm not going to drink, but your body's craving it, or your behavior, or your psyche. It's like, well, I miss my friends. I miss my friends. I got to go see my friends. Well, you saw your friends when you were all drinking.
Yep.
So you get back into it. It's the same struggle in a different way, because the opioids have really reconfigured your brain structure, where alcohol doesn't do that except for over a long, long, long period of time. But it's still that dependency. And at times, those drugs or the alcohol is connected with a social environment,
Oh, absolutely.
which is a real draw.
Which is why you've got to change your lifestyle.
That's not easy to do for an
I
alcoholic. It's not easy to
understand.
do for someone with an addiction. Doesn't matter what the addiction is. There's a grip. We do the best we can. And we want to make sure for folks who are incarcerated, when they go out, they don't come back. And we want the public to be safe. And if they come out and they're looking for drugs within the public, it's not safe. So how do we, it's not going to be 100% successful.
They're looking for drugs, they're looking for the money to get the drugs, they're gonna steal stuff, blah, blah, blah. It's a cycle.
So let's finish our draft here. We flagged the trainings. We can take some testimony on that from DOC, from state employees.
Okay. So subsection I don't know if it makes sense to really spend much time on this, because I think this is just something you're still working through. But this is the issue. How do you want to acknowledge that a contractor is doing this work? So I'll leave it there. I'm sure you'll have a discussion about it and I can rework it however the committee feels appropriate. When we met a month ago, there was also an interest in an annual report from DEVA to track some information. I said I'd put language together, but I was also asked to sort of flag this as something that you need more testimony on, that you might have other data points you want to collect on. So I would just flag for you that this is a stab at it, but it sounds like there's more work to be done on this particular paragraph. So this adds to existing language, annually on or before January 15th, DEVA, in consultation with DOC, shall submit a report to the various policy committees containing an aggregated number of previously incarcerated individuals re-entering the community in the past year who were receiving medication for opioid use disorder at the time of release. And of those individuals, the aggregated number of individuals who continue to refill a prescription for medication for opioid use disorder 6 months after re-entering the community.
I think this is a concern you brought up, Kevin, right?
Yeah. Well, I'd like to know how successful it is as opposed to, well, it's sort of like teaching safe sex as opposed to abstinence. Which is more successful? It's the same kind of measure. Are we really accomplishing what we hope or not?
I would find this useful.
You'd find it what?
Useful.
Useful. So we should probably reach out to DEVA to see if they could do anything like this. Would be good. Just to touch base with them.
I think DOC also had a comment on this section.
did?
DOC.
DOC, yeah.
And then the effective dates. You have this taking effect July 1 of 26, except that section 3. Oh, except that section 3 should be section 3 shall take effect July 1, 27.
In section.
So I have two sections.
That's the report, right?
The report, so you have time to
The data.
But why were we so far out on the first one? the 26th?
because you haven't made crossover. So the idea is that this wouldn't pass till next year.
Okay.
Yeah.
Thank you.
To the realism.
Sorry.
I bring in something new.
Mhm.
Not new, it's not new. It's something that's kind of still just, I haven't let go of. And Tony, this is mostly for you. I'm still really interested in considering all the benefits of bringing injectables into this deliberately, not just as a, so Tony, from you, like, where are injectables on the overall best practices scale right now? This is why this is important for me. I think it would address diversion in a real significant and immediate way. I remain very concerned about the timing and the scheduling of administrating MOUD, right back to the stories of people who are woken up 2, 3 o'clock in the morning just to get them in line. And then the administrative burden of continuing to administrate the MOUD in its current form. So, and I know that there's a cost involved with that, but for me, the cost feels appropriate for all of the benefits that we might gain out of injectables. But Tony, the first question is, where are we on injectables just nationwide as best practices?
In the uptake of injectables is quite low still. So most folks are using oral medication as a first line. I relate it much the same way as I do to psychiatric medications. Normally you don't move to injectables, or most folks don't move to injectables or are willing to take injectables until they've tried the other forms of medication and have found them to be unsuccessful. I think in this state, we probably, I don't know the exact numbers offhand, but we're probably out of 9,500 people roughly receiving medications for opioid use disorder. We're probably in the 150 range of people who are taking it injectably. So it's a small percentage.
But given the differences, the very specific conditions within a carceral facility, is it worth considering like we're going to move to injectables because of the diversion problem, because of the scheduling, because of the administrative burden?
I think it is worth looking at. You've got a plus minus on this one for me.
Yep.
The plus is the things you're describing. The minus is the fact that upon release, we're going to have a very limited pool of providers who provide injectable medications. So we lose access to folks who are coming out that right now have broad access to medications when done orally or under their tongue.
What do you think the timeline, like, is there going to be any movement toward more universality of injectables?
Again, most patients in the community don't want it. So most providers don't increase the number of injectables because that's not what their patients are asking for.
Okay.
But I understand what you're getting at.
Yeah.
Because it could be a cost savings with all that the
Yeah.
injectables are quicker and work better. I get where you were going with it.
Yeah, but I also struggle with all of those things. I really think we should pick at, but mandated injectables when you know you can't get it when you're done, that to me feels really,
That's going to create a real problem
Yeah.
on reentry.
yeah.
New York
That could
State did
exacerbate.
this. When New York State, we were talking to the folks in New York State, because we too have been exploring what's the use of injectables in other states. New York State said they kind of moved toward, in their Department of Corrections initially did injectables, and they had no community providers available to do it. So they did it in isolation, and folks were leaving and hopefully getting onto oral medication upon leaving because they were not receiving injectables upon leaving. So it's figuring out what is the will of the individual, because we certainly don't want folks who need medications to refuse it because we're only offering an injectable form. I would say the flip side of that is we don't want to be in a position where folks who we know are at high risk of diversion are being released into a situation of high risk to diversion. And what we've historically done with those individuals in particular was to shift them more often to methadone, which has a lower diversion potential, a higher lethality risk if it is diverted, but also has a higher monitoring structure upon leaving, because at least interimly folks are being seen daily or regularly until they stabilize enough that we can give them take-home medications. So that's been the workaround historically.
Yeah. Thank you.
Yeah,
So Tony, you've been with us as we've walked through the draft with Katie. Are there parts of the language, parts of the draft that you want to weigh in on at all?
No, Katie, I can say that in your question about the rule change, the rule name, we did change. Actually, we removed for buprenorphine out of the state MOUD rules. So we had just moved that to office-based opioid treatment, both in expectation that even though naltrexone isn't uptaked very much, comparatively speaking, either oral naltrexone or Vivitrol, which is the long-acting injectable version at this point, we were also hoping that at some point we will have more than 3 medications that can be utilized for the treatment of opioid use disorder, because right now we really are limited to just 3 medications that may have different delivery systems, but the pool of options is still quite limited for the number of people who might benefit from the medications.
So Tony, before we finish up, I just want to pick your brain a little bit in terms of who from the medical field in your world should we have come in and testify? I know we talked about possibly having some folks from the hub and spoke arena. on the outside. I'd also like to know, do you have any thoughts? Or maybe Katie does too, because this is more your world than our world, to weigh in on the term of healthcare practitioner, just so that we understand that more, what that actually means.
Mhm. My actual thought was OPR might have a suggestion for language about how to capture providers who are licensed out of state.
Okay. So Tony, do you have any thoughts?
Yeah, depending upon when the committee would want to take testimony, DSU has a contracting medical director, Chris Laconis, who has been both a methadone provider as well as a buprenorphine provider. Dr. Laconis will be out of state this month. So if we're looking in this month, the person I would probably request would be Dr. Brooklyn. And I say that in the fact that a lot of the questions, particularly Representative Hedrick, you're asking, those kind of research questions, John Brooklyn, not only as a community practitioner doing both buprenorphine as well as methadone in various settings, but was also part of the clinical trials. He was the medical director for the University of Vermont clinical trials as they were actually bringing buprenorphine on board. So he has both the historical knowledge of the clinical trials that he helped oversee that allowed for buprenorphine to become a medication utilized for treatment of opioid use disorder, but also has been involved in clinical trials subsequent to that. So from a research standpoint and where research meets practice, I think Dr. Brooklyn would be the person I would respect most in that.
He's here, is he with the Department of Substance Use?
He is not. He's at the University of Vermont. He's at the Chittenden Clinic, and he is also at the federally qualified health center in Burlington.
Okay, could you give that contact, if you have that contact information, could you give that to Phil? Patty?
Absolutely.
And then is there folks from the Hub and Spoke that could talk about how they operate when what they see with folks who are reentering from an incarcerative setting and what the process is on their end?
Sure. I think Dr. Brooklyn could speak to it on one side, again, because he does the practice piece. Probably Dr. Fred Lord, who's out of Windsor. He has a large outpatient opioid treatment program, office-based program. He also is the medical director for the West Lebanon hub. So even though it's in New Hampshire, it's 500 yards over the border and treats more Vermonters than it does New Hampshire residents.
Yep.
And has done a lot of work with his kind of local criminal justice folks, as well as being the most recent past president of ASAM of Northern New England, or the American Society of Addiction Medicine of Northern New England. So he can carry in a much wider perspective as well.
That would be very, very helpful.
Yep.
And so we also need to have DOC come in and talk about the language. Not kind of pie in the sky talk, just really refer back to the language. And also VSEA in terms of the training issue.
Yep.
And what they're seeing, also VSEA, what they're seeing from their staff for folks, how the staff operates during the time of Medline or when they're receiving the treatment. They're lining up and spending a lot of time in the facility, staffing this. And also the WellPath folks from DOC should be here as well and talk. And talk about the new language too. So I'd like to see if we could schedule some of that next week. It might be tough because it's Friday, but if we're going to continue working on this bill, we really got to start taking a lot more testimony here.
Yeah.
From that. Any other thoughts from the committee? Direction?
No, but Tony, is that a duckbill platypus on your shoulder?
It's a dog.
Yes, my dog actually believes he is a cat. So Whiskey is the name of my dog. He likes to come up onto the back of my chair and kind of make sure he's seen on every camera that I'm ever on, and B, wraps himself around my neck similar to how a cat would do this.
At first I thought it was a really large squirrel, but I wasn't sure.
Well, I wasn't sure if it was a cat, but I knew it didn't have that type of nose, so.
I just teased.
But I understand a cat around the shoulder. I understand that really well.
Good to see you. Thank you so much.
Anything else before we finish up for the day? Katie, thank you, and we'll keep working on the bill.
Sounds good.
And Tony, we'll keep you in the loop whenever we're having testimony on H32. We'll let you know when it is. If you have time to come in, you're more than welcome.
Absolutely. I appreciate it. I thank the committee for inviting me at any time. And Phil, I'll be happy to get you contact information for both Doctors Brooklyn and Lord.
Right, thank you.
Thank you. Great, thank you. Thank you, Katie. Thank you,
Thank you.
Tony.
A good weekend.
So for the committee.
Thank you, everyone.
We are done for the day on YouTube. You folks can go home for the afternoon. I'm still scheduled to go into Senate institutions at 1 o'clock, present the Capitol bill.
Got Wendy riled up for you yesterday.
Good.